Good morning. Greetings from Hyderabad, city of pearls and biryani. Thank you very much for giving me this opportunity to be part of your great meeting. I'm going to talk about my journey from conventional to robotics. I started doing TKRs in 1993, all conventional. Now started doing robotic, fully active robotics. Why computers are technology more suited to orthopedics? Because the bony structures and anatomical relationship remain stable between time of image capture and the surgical intervention. The use of technology was first published of case of computer-assisted surgery in orthoplasty in 1997, and you can see various companies started bringing up their own technology. Computer navigation is a part of broader field of computer-assisted surgery, and computer-assisted surgery refers to surgical interface between surgeons and computer machines. Why do you use in TKA? It is an established fact that longevity of total knee prosthesis depends mostly on correct alignment of the prosthetic components in a frontal, sagittal, and axial, along with soft tissue balancing, restoring mechanical weight-bearing axis of the lower extremity in that particular patient. Why did I change from conventional to computer-assisted devices? Because there's so many results or publications are coming up which is showing better alignment and probably better outcomes. The early days of prosthetic surgery measured success with respect to pain, then mobility. Attention is on the function expected by the patients, although the results of pain and range of motion are generally satisfactory. Recent publication gave an account of non-optimal functional results between 50 to 34 patients of the patients who have undergone total knee replacement. And you can see these are the publications with the results which are not to some extent acceptable. And it's widely acknowledged that poor alignment of total knee prosthesis represents negative factor with respect to the function and the longevity of the knee implant. So it's important to improve the alignment. So knee navigation trends from 2003 to 18. The adoption of computer navigation differs among countries. Computer navigation was first introduced in Australia, and in Australia, the biggest numbers are done, as you can see in the graph. So the accuracy of alignment guides, as you can see, tibial extramedullary is about 70 to 90% accuracy. Intramedullary is about 94% accuracy. So there is still scope for improvement. Again, femoral alignment guides, you can see intramedullary is better than extramedullary, but still you have a scope for improvement. This classification can be done based on categories, can be active robotic systems, semi-active and passive systems. Classification can be based on input data. It could be CT based, fluoroscopy based, or imageless systems. And as you can see, the components of the optical camera to pick up the infrared light, electromagnetic coil to pick up the electromagnetic pulses, and ultrasonic probe to pick up the ultrasonic waves. These are the tracking systems which are available. So the components which are aiding surgical process active markers or arrays, passive markers or beads or arrays. The workflow is tracking system to patient body or bone. Then you enter the data and get the display on the monitor. Created virtual image allows enhanced capabilities such as prosthetic sizing, bone resection level, as well as kinematic assessment. Fixing the pins which work dynamic reference base to femur and tibia, which will record the motion. The hip center is determined using kinematic referencing by rotating femur at the hip joint. So there are limitations using imageless technology because various factors, especially finding intraoperative bony landmarks, sometimes could be difficult and variable from person to person. And potential errors can happen because the data we feed may not be as accurate as image based. As you can see, the advantages. Why do I choose QS? It's a fully active robotic system. It's a CT guided system. Accuracy of bone cuts more precise than saw based systems. Uses both the principles of imageless and image guided workflows to increase the accuracy. Robo, which is very motion sensitive and touch sensitive, both required for safety of patient and increasing the accuracy of the bony cuts. Also, of the data collected on the Google searches, with my background of doing computer navigation and seeing the results, was searching for something better than navigation, so robotics, thus minimizing human error. Though I don't consider myself young, but do not too old as well, and still have to have the fight to adapt myself to newer emerging technology trends, which will help me to survive in the competitive world. Short-term results, you can see this is demonstrated a good result. WOMAC and KU scores are better with robotic assisted total knee replacements. Also, surgeon factors associated reasons reduced mental stress of encountering intraoperative unwanted situations and helps decision making before surgery, reduces burnout in high volume surgeons, reduces chances of complications and intraoperative errors caused by the fatigue of clinical and psychomotor skills. So how do I do my planning? Planning done on the day prior, doing the planning personally, delegating specific work to each person in the team and discussing with them how to reduce the workflow time and thus decreasing surgical time, monitoring robotic arm movement in a way that it should not block the vision of the camera, connecting the reflective markers, thus reducing the incision length, putting the pins in the metaphyseal bone area, reducing the risk of postoperative pin track fracture and reducing the incision length as well. Balancing the knee during planning in a way to reduce the need to do ligament release and correct the deformity completely. Future of computer-aided robotic system. Development of computer-aided robotic system would address major challenges in TKA, enabling less invasive surgery. Less invasive TKA could potentially enhance patient recovery and function following TKA. Robotic systems may aid in this procedure by guiding surgeons' actions when the visual field is limited to smaller incision. Make surgeons more precise by guiding them to avoid fallacies, implant malposition, minimal soft tissue release. You can see the intra-op pictures of a robo burr cutting the femur. and you can see on the monitor the safe zone, and the burr is going to cut within that safe zone. So with haptic feedback, and you have all the measurements here, which how much is going to cut, whether you planned the same amount and you're executing the same. And I find it more useful in doing the posterior femoral cut, because we leave a margin of the bone on the posterior part of the femur, so that the important structures, vessels and nerves are protected, and you take that rim with the nibblers. And of course, you can see the measure cut surfaces. You can check it, the accuracy with the your probe, whether what you planned and what you executed. You can see it's only few millimeters difference of planning and execution, which is very important to get good alignment. And as you can see, one of these case, the preoperative planning was on the medial side. There's a 5 millimeters gap in full extension, 10 millimeters on the lateral side, which after post surgery you can see 9 and 11, little lax on the lateral side, which is acceptable, which should be there. And in the flexion, 90 degrees flexion, it was tight on the medial side, only 5 millimeters, 8 millimeters on the lateral side, which is balanced after doing the resection. You can see it's 9 and 10. And one great lesson what we learned from robotic systems are, we are doing a minimal soft tissue release. And most of the time we are doing the deformity correction at bone resection. That shows the ligaments, especially medial and lateral ligaments, are not contracted. And if you correct the deformities at the bone level, the ligaments will be balanced properly. Thank you very much for your patient listening. I hope I shared some information which is useful in your day-to-day practice. And as I said, the technology is very important. We have to integrate technology, and robotic systems are very useful, especially image-based one, because we have a fixed landmarks in most of the surgeries. To be in the competition or current practice, we have to be up to date with the latest technology. Thank you once again. Thank you for giving me this opportunity.